So I'll be talking, so you get two of us in this session. I'm Peter Forsberg. This is my partner, Jeff Matous. As they mentioned, we're both out in Colorado at the Colorado Blood Cancer Institute, where we're the myeloma the WM program. And this is my first Ed Forum, so for anybody else who's a first timer, I'm with you on that. So welcome to everyone. And we're going to be doing the basics. So we're going to be talking, for some folks this may be a bit of a refresher. The hope is that we can kind of get pretty basic and fundamental on what WM is and sort of how we start to parse it. So here's the things we're going to try to cover. What exactly is WM? How do we diagnose it? What kinds of problems can it cause? When do we treat it? Not so much how do we treat it. There'll be sessions this afternoon on how we treat it, but when and why. How do we track it over time? What are some of the unusual presentations of WM? And how to be a bit of a successful WM patient, how to navigate your care team and your diagnosis. So I always think to understand one of these problems, you wanted to get very basic, and sort of the story of WM begins with Waldenstrom. So this is Jan Waldenstrom. He was a Swedish pathologist. He practiced through most of the 20th century, and in the 1940s, he described the first cases of a couple of patients who had nosebleeds and anemia and enlarged lymph nodes, and in looking at their blood, he was able to characterize that they had this abundance of a large antibody, which became IgM. And so, 80 years later, we still use his name to describe the disease that we're going to be talking about. But to define WM, it require two components. Okay, so Waldenstrom's is for the label WM to be appropriate, you need both an IgM monoclonal protein and lymphoplasmacytic lymphoma, generally in the bone marrow. Okay, so IgM, that's where the term macroglobulinemia comes from. Macro meaning large, globulinemia being an antibody in the blood. So that name comes from the IgM itself. And then, there are people who have monoclonal IgMs which are not associated with lymphoplasmacytic lymphoma. So patients with chronic lymphocytic leukemia, CLL, or marginal zone lymphoma, some other lymphomas may have a monoclonal IgM, but they don't have WM. And in those patients, we would treat them like we would treat other patients with CLL or marginal zone. Lymphoplasmacytic lymphoma, that's the abnormal cells that give rise to the IgM production. And so, similarly, you can have lymphoplasmacytic lymphoma that doesn't make IgM. So about 5% of LPL patients make IgG or other antibodies, but those patients we actually do treat like WM, although their complications may be a little bit different because they don't have that IgM-related risk that comes specifically with the big antibody. So you need to have both to be WM. What it is also not is it is not myeloma. That's another adjacent condition. The behavior of myeloma, which comes from plasma cells, is totally different, but differentiating between them can be sometimes a little complicated. So to get at what WM is to think about what LPL is also. So lymphoplasmacytic lymphoma, that's the name for the lymphoma cells that give rise to WM. What they are is kind of right in that name, lymphoplasmacytic. So, that means that they often are kind of in this differentiating phase between lymphocytes, which are some of your B immune cells, and plasma cells, which are the finally sort of mature B lymphocytes. And so it's not unusual that when we get a bone marrow result in a patient with WM, they're describing a portion of the cells that look like lymphocytes and a portion of the cells that look like plasma cells, and we get kind of percents of both because you have cells that kind of look more like lymphocytes and others that look more like plasma cells, even though they're from the same process. And they tend to live mostly in the bone marrow, but can also be in the lymph nodes or spleen or liver. And then these are the cells that, cause problems along with the IgM that may cause problems. And in terms of thinking about LPL, I always tend to think it's helpful to think about where lymphomas start from. So basically, throughout their development, B cells can, they go through different stages. They start in the bone marrow at their most immature phase. These cells, if they become abnormal, if they have a change in their machinery that makes them a malignant cell, they give rise to things like leukemias. When the cells move, in their development, the B cells then move to your lymph nodes where they go through a maturation process. And at any stage in that process, if a change happens, they can become a different type of lymphoma. Near the end of that differentiation, they move back to the bone marrow, which is where the cells most of the time that might give rise to WM live. And then eventually they become plasma cells, potentially. So that's in terms of B cell development. The other way to think about lymphomas is to think of this kind of taxonomy of lymphomas, because basically lymphomas are kind of complicated. There's more than 100 different types of lymphomas, and knowing where you fit into that can be impactful. So with lymphomas, we tend to start by thinking, is it Hodgkin's or non-Hodgkin's? About 15% of lymphomas are Hodgkin's, 85% are non-Hodgkin's. Then is it T cell in origin or B cell in origin? Those are your different types of lymphocytes. T cells are much less common than B cells, so most of our non-Hodgkin's lymphomas are B cell lymphomas. And then within B cell lymphomas, is it an indolent or an aggressive lymphoma? Those are pretty fundamental distinctions. Aggressive lymphomas are it's in that name. They develop more quickly, they often make people sicker, and our approach to them is often geared around intensive chemotherapy to a degree to try to potentially cure the lymphoma, whereas indolent lymphomas are generally not curable. That's kind of intrinsic to their nature. They often grow more slowly. That doesn't mean an indolent lymphoma can't behave aggressively, but there are some fundamental differences in how they develop, how they might persist, and so our approach to treatment is a little bit different with indolent lymphomas, and that's where WM fits. So WM is a non-Hodgkin's B-cell indolent lymphoma, similar to CLL or follicular. Those are the most adjacent sort of lymphomas. And then, of course, with WM, the IgM is a big deal. So what is IgM and why does it matter? So IgM is one of 5 different antibodies your body makes as a response to infections or other sort of foreign triggers. You make IgM, IgG, IgA, IgD, and IgE. You may see that a couple of those are not ones we measure routinely. So we often monitor the IgM, the IgG, and the IgA. Those are the most prominent in the blood. IgE is more related to allergy-type reactions, and IgD is just less common. But IgM is kind of unique in comparison to that IgA. You see that IgA, these are my antibody hands. You have 2 what we call heavy chains, those kind of blue things. Those are like the scaffolding of the antibody, and then you have those 2 pink light chains. So those help with specificity of what the antibody is going to bind to. So an IgG has just 2 heavy chains, 2 light chains, all bound together, whereas an IgM kind of has 5 of those, all attached with bonds. So that makes it much bigger, and it has some sort of functional differences. It's also our first responder. So if a patient's sick with an infection, and we're trying to understand, is that a new infection or something that might have come back for some reason, IgM can help us differentiate that. So if you were to catch a flu, the first thing your body makes is an IgM to respond to that. So as most of you guys know, WM is not the most common condition. It's a relatively rare disease, although, as we get better and better with treating WM, there's always going to be more patients living with it because patients are living longer, doing better. But we diagnose about 1,500 cases in the US each year, which makes it about 1 to 2% of all blood cancers. It's more common in men, about twice as common. It's more common in Caucasians, about twice as common as in other racial groups. The biggest risk for WM is getting older. So essentially, it's pretty rare that we diagnose WM in folks in their 30s and 40s, about 10% are younger than 50. So with each decade of life, it gets a little bit more common, and the average age of diagnosis is in the mid-60s. One of the first questions that always comes up when somebody's diagnosed with WM is, what triggered this? What caused it? And the truth is, we generally don't know. We don't have good explanations for what the drivers are, although we do know that there may be some things that increase the risk to a degree. So there's no single, cause, no diet, lifestyle, infections that might have triggered it. Immune system activation can be an increased risk. So people who live with chronic immune activation, usually through autoimmune conditions or chronic infections, may be at slightly higher risk. That's actually more true for some other lymphomas than for WM, but it may increase the risk for WM a little bit as well. Family history is meaningful. Patients with WM, about 1 in 5 of them have a relative, a first-degree relative, a brother, sister, children who have another B-cell disorder. Not necessarily WM, there's an increased risk for other things as well, including CLL and other lymphomas. But almost everybody who treats this has families that they treat where people who have siblings or kids who deal with the same condition. And having a first-degree relative with a blood cancer increases your risk of developing WM by about 65% over the course of your life. So what we have characterized, and this is what Dr. Treon was getting to this morning a little bit, is better understanding for what makes a normal B cell become a WM cell. So, that's pioneering work by Dr. Treon and others that have characterized what happens to your normal B cell to make it a WM cell. And the biggest trigger by far is a mutation in what's called MYD88. So it's easy to think of MYD88, which has one very common mutation called the L265P mutation, as being the on switch for most patients' WM. This mutation happens at some point. We don't know why, but it's very consistent across WM patients. There are a portion of patients, about 5%, who don't have MYD88, and that tends to be a little bit trickier in terms of figuring out how to treat those patients. After the MYD88, people sometimes develop secondary changes. So the most common secondary changes that happen within patients are CXCR4 mutations in 30 to 40% of patients, and then P53 abnormalities in about 15%. CXCR4 we'll talk about. P53, that's a tumor suppressor. So basically when that's changed, it means cells don't regulate their life cycle in the same way, which may make them behave differently over time. And it can be an indicator of a more aggressive behavior of WM. So MYD88, if you remember one thing about what changes in the cells to drive WM, it's MYD88. So this cascading thing is the B cell signaling pathway, and basically that all comes together for a B cell to turn on. So basically your B cells should have periods where they're active and periods where they're quiescent. Most of the B cells in your body right now aren't doing anything. They're just there in case something stimulates it to then go into action and to make an antibody in response to an infection. And the way they do that is with this kind of complicated molecular signaling cascade. And part of that signaling cascade is MYD88. So it's nestled right up there near the top, right next to BTK. So, it's kind of a logical thing to target BTK because it stands right next to MYD88 in this signaling pathway that basically turns a WM cell from a normal lymphoid cell that has an on and off switch into a lymphoid cell where the on switch is constantly activated, okay? CXCR4 is more complicated. I don't know that I totally understand CXCR4. It's part of cell functioning as well. It's a much bigger protein. It's got these loops that go up and down between the inside and the outside of the cell, so it's a much larger molecule. And the changes that happen in CXCR4 in WM are more complicated. So it's not just one mutation that turns it on. CXCR4 is part of how cells bind and live in their environment, so activation of it helps anchor cells into the bone marrow. So that's maybe why patients who have abnormal CXCR4 are more likely to have higher amounts of their WM in their bone marrow and a greater amount of IgM in their blood. So it does change the profile of patients with CXCR4 mutations versus wild type. That's the name for if you don't have a mutation, we call it wild type. But basically, and this also may inform treatment choices and expectations a little bit. Most of the abnormalities happen in that little squiggly bit near the bottom. That's the C-terminus domain. And there's different types of mutations that can happen. But in patients who have abnormal CXCR4, if we start them on a BTK inhibitor like zanubrutinib, we should expect that responses are going to take longer than they would otherwise. But we have, and that might impact what makes the right choice for a patient at a specific moment in time. So how do we diagnose WM? Most of you who've been diagnosed probably went through these tests when you were first diagnosed. We're going to do blood tests, and Dr. Matous is going to talk more about those specific blood tests. There's some that look for abnormal IgM and try to measure it. There's some that look for complications of the WM, like CBCs and metabolic panels to look for blood count abnormalities. There's some that look to stratify how aggressive the WM might be, like LDH and beta-2 microglobulin. We do a bone marrow biopsy, standard, to help make diagnosis. That's where we can identify that lymphoplasmacytic lymphoma, as well as look for genetic components like MYD88, CXCR4, and P53 abnormalities. And also it can help us to predict how likely the WM is to cause problems. In a patient who's not symptomatic, greater involvement of the bone marrow, a higher percentage, predicts a higher likelihood that they'll run into problems over time. And then usually we need some form of imaging, either a CT scan or a PET scan, to look for abnormal lymph nodes, spleen or liver abnormalities, as well as a good history and exam. And in patients with concern for possible hyperviscosity, we do need usually an ophthalmologic exam to look at make sure there's no changes at in the small blood vessels of the eye. So one of the fundamental things to think about with WM, as well as other indolent lymphomas, is that not everybody needs treatment at time of diagnosis. I know there's some watch and wait folks here in the room for sure, but at the time of diagnosis, a substantial portion of people are asymptomatic. The IgM, the LPL is not causing problems, and those patients don't need treatments. So we often find patients who are pre-symptomatic or asymptomatic, and really our decision on who needs treatment and which treatment to choose for the WM is driven by symptoms developing. So for many patients who are found that are asymptomatic, watchful waiting, monitoring the IgM, monitoring emergent symptoms is the right initial choice. And, I think of these conditions, WM, as falling on a continuum, because pretty much everybody who has symptomatic WM went through a period of time, whether we knew it or not, where they had asymptomatic WM, where they had an abnormal IgM in their blood and abnormal cells in their bone marrow before it built up to the point where it started to cause symptoms. So if those patients have an IgM M spike in the blood, but less than 10% bone marrow involvement, we call that IgM MGUS. If there's more than 10% bone marrow involvement, but no symptoms with an IgM monoclonal protein, we call that either smoldering or asymptomatic Waldenstroms. Patients may have less than 10% involvement and a pretty small IgM, but develop complications from their IgM. So we might call that an IgM-related disorder, and Dr. Matous, Jeff will go through some of those. And then macroglobulinemia is kind of when things have built up. The cells in the bone marrow have built to a greater degree, the IgM's gone up too much, and that's the reason why we're having problems. But at time of diagnosis, WM patients have very diverse symptomatology. The most common symptom is fatigue and anemia. About a third of patients maybe have hyperviscosity. Now, some of this is like 25 years old. We don't keep doing the same thing of evaluating 1,000 WM patients and seeing what their symptoms are. But it is pretty diverse in terms of symptoms, including things, what we call B symptoms. That would be like fever, chills, weight loss that's otherwise unexplained, bleeding complications, and neurologic complications in almost a quarter of patients. And when I think about the problems WM causes, I tend to break them down into two buckets. One is problems caused by too much or bad acting IgM, okay? So when you're thinking about what problems WM causes, why we might need to treat, one problem is, IgM behaving badly. So when it's too much, that generally triggers what's called hyperviscosity, which many of you are sort of familiar with, either having heard about it or experienced it, unfortunately. And so basically with this big, bulky pentamer of IgM, this five-sided antibody molecule, if it accumulates too much in the blood, and usually that happens when the IgM level gets into the 5, 6, 7,000 or higher range, it can start to shift fluid dynamics through small blood vessels. And that leads to things like blurred vision, headaches, dizziness, and easy bleeding of the gums or nose. Then there's other conditions that come less from too much IgM and more from if the IgM does bad things. So it can bind to your nerves and cause direct nerve injuries through neuropathy by binding to the lining of the nerves. If, in temperature changes, sometimes the IgM has different changes in its molecular behavior, and it can bind to red blood cells or to other antibodies and cause things like agglutination, that's red blood cell clumping, or cryoglobulinemia, protein clumping. And for a variety of different reasons, it can lead to bleeding issues, which Dr. Matous will talk more about also. And then there's problems that are caused more by the LPL cells building up, okay? And this is actually the reason why we do treatment for most patients. The most common complication from LPL cells building up is bone marrow compromise. They reach a point in the bone marrow where they accumulated and you become anemic. Good blood production is just crowded out. So anemia is our most common indication for treatment. And that can also cause things like low platelets, which is thrombocytopenia, which increases bleeding risk. And many people live with low antibody levels kind of just because these abnormal cells are not good neighbors to normal immune cells. But also it can cause lymphadenopathy if instead of the bone marrow, if the LPL cells tend to, some patients, they grow more in the lymph nodes or in the spleen or liver. So if those areas were to grow because of LPL cells building up, that's another thing that can be a problem that's caused and a reason for treatment. But we try to be kind of systematic. So, part of our job as WM experts in the WM community is coming up with guidelines that can be used any place, so that if you're seeing a provider outside of a WM center, they have good indications for who needs treatment and who doesn't. So we do have what we call consensus guidelines for who, whether that's related to, marrow or tumor infiltration, things like anemia. We generally wait until the hemoglobin is below 10, and in that setting, we need to make sure it's not something like vitamin deficiency or iron deficiency that's driving the anemia, that it's really the accumulation of the WM cells. Same with low platelets, constitutional symptoms, fevers, night sweats. Things like fatigue can be tough. So we have to be pretty thoughtful about who we treat and why. But we do have guidelines and guideposts for us that we should always be transparent. If your doc's ever recommending starting treatment, you say, what's my primary indication? Why do we need to do that? And then I would say that, we won't get too in the weeds with this, but different indications for treatment may be best served by different treatment approaches. So basically if you have hyperviscosity or if you need treatment because the LPL cells in your bone marrow have built up enough that they're compromising bone marrow function or they're invading your lymph nodes and causing big bulky lymph nodes, then generally we need something fairly robust in terms of our treatment approach. So that would be something like chemoimmunotherapy, like BR or a BTK inhibitor, whereas there may be some indications like IgM-related problems where you don't have as as many LPL cells, but the IgM is a bad actor where things that are less intensive, like just rituximab, may make sense. So different indications may be best served by different tools to a degree, but there is some real nuance to that. And then just for one treatment detour, it is, useful to know what plasma exchange is. So, we mentioned that IgM accumulating is one of the big triggers for potentially needing treatment, and it is an urgent thing. So if you're symptomatic, with your IgM buildup from hyperviscosity, then one of our main tools that we need to use quickly is what's called plasma exchange, and that's a mechanical process where we're actually going to use IVs, either 2 in your arms that are relatively large bore, or a big one in your chest that's going to allow us to run your blood through a machine where we can separate your plasma, which is basically the part of the blood that has the proteins but no cells. We're going to separate that out and get rid of as much of that IgM as we can over the course of a couple of hours, and then replace that with either albumin or albumin plus donor plasma. And so that we're going to replace your blood with less thick blood that doesn't have that IgM. And because most of the IgM in your body is actually in the bloodstream, over the course of a couple of sessions, we can relieve symptoms pretty consistently and keep people into a safer place. It doesn't treat the lymphoma itself. So, plasma exchange is kind of a temporizing step. It helps us to get back somebody who's having symptoms from the hyperviscosity and the IgM itself, but it doesn't necessarily get us, towards that control of the lymphoma more broadly. We do have to be thoughtful about rituximab as well. So if a patient's going to get rituximab, there's about a 25% chance that can cause an IgM flare, which could tip somebody into hyperviscosity. So in addition to patients who are symptomatic from hyperviscosity, we also often do plasma exchange for patients who are at risk for hyperviscosity before they start rituximab-based treatments. Okay, so that's my half of the talk. I'm going to turn it over to my colleague Jeff, and he'll do the less common stuff.
Thank you, Dr. Forsberg. Again, it's always a pleasure to speak at the Educational Forum, and it's great having my colleague, Dr. Forsberg here, who's, I think, going to be a regular attendee in the future. He's so good with explaining things. So anyway, I'm going to talk about Pivot a little bit. So Peter covered what WM is and that kind of thing. I'm going to talk about some tips for how to be a good WM patient and what some rare things to look for. So the first thing is WM patients need to be really aware of what their disease is doing and how it's behaving. You have to do that, because the odds are most of you are being treated by docs who might just see a couple of WM patients maybe a year, or just take care of a handful of patients. And so you need to be the WM expert. You need to be your own WM expert. And so I say no ostrich strategy. And one thing I learned when I made this slide, which is sticking your head in the sand, is that they're not really sticking their head in the sand. They're messing with eggs when they do this. And so I learned that when I made this slide, but I still keep it because I don't want you sticking your heads in the sand when it comes to tracking your Waldenstroms. So the savvy WM patient knows how to track the behavior of their disease. And one of the key things is following your labs. You have to know what your labs are doing. And I always say, keep a notebook or keep an Excel spreadsheet on what your labs are doing. Educate yourself about what the labs mean. And then know your WM symptoms, which Dr. Forsberg covered. So we're going to go over some labs here, and I hope this projects well on the screen. So this is a copy of a CBC, which stands for complete blood count. And this may have been the way you were diagnosed with WM. Because like Peter said, a large proportion of patients who end up getting symptomatic or needing treatment for the WM do so because they're anemic. So how is anemia determined? It's determined from a complete blood count, or a CBC. This is a copy of a real patient with Waldenstrom's and their CBC. So what information can we get from a CBC? Well, one thing we can look at is the white blood count. And the white blood count occasionally in Waldenstrom's is low, often from treatment, but sometimes it's high. Sometimes the WM patients who have a lot of WM and LPL in their bone marrow will circulate these lymphoma cells in their blood, and that will go high, but this is a normal white blood count. Now, we look for anemia through what's called the red count, and the red count is measured by the hemoglobin and the hematocrit, and you can look at both of those, and some docs are going to talk to you about your hematocrit, some docs will talk to you about your hemoglobin, and rough rule of thumb is hematocrit is 3x the hemoglobin. But this patient, as you can tell here, the pointer only works, let's see, Anyway, I don't know if I have a pointer, but anyway, if you look at the CBC here, on the far right it has the range. And so a normal hemoglobin is between 12 and 16, certainly higher where Peter and I practice due to the altitude. And this patient's hemoglobin is 8 and their hematocrit is 24. So this patient is pretty significantly anemic and almost certainly quite symptomatic from that. The next piece of information we get is the platelet count. These are blood clotting cells. And usually not a big issue in WM, but occasionally they can get really, really low in WM, and I'll address that in a few slides. So complete blood count, you're looking at the white count, the red count, the platelet count. You can get a lot of information about how the WM is behaving. There's our anemia right there. So this is a chemistry profile. And so many of you in the room here who were diagnosed as what I call incidentally, were diagnosed because you had a chemistry test done, and the doctor noticed an elevated total protein in the blood, and we started going on a wild goose chase. But there's a lot of information we can get from a chemistry test, and one of those is the kidney function. And the kidney function is measured through what's called the creatinine. And ballpark normal for someone is 1. For petite people, it's a little bit less than 1. For big people, it's a little bit more than 1, but that's ballpark. But the one thing where the WMers often get into the club is when they're having their chemistries checked and their total protein is elevated. And the total protein is elevated, and that's where the IgM actually hides. So in a normal chemistry test, the IgM is not measured on a normal chemistry test, but it's part of the total protein. And so if you look at your labs and the total protein's high, then your doctor is going to go, I'm going to check this again. And if it's elevated, they're going to order an additional test called an electrophoresis, a serum protein electrophoresis. And the normal one is on the top there. And what an electrophoresis does is separate proteins out in your blood. And there's certain, like the albumins are a very high percentage of your blood. That's the big peak to the far right there. And in where the Greek letter gamma is in the far right, that's where the IgM hides. So in that case, in the top one, the IgM is normal. But in the bottom patient who had the elevated total protein, and when you had the serum protein electrophoresis, it showed that big spike in the gamma region. So that's called a monoclonal spike. And I bet many of you in the room here who had an elevated total protein and an electrophoresis that showed a monoclonal protein spike were told that you had multiple myeloma. And that's because almost all the cases of monoclonal protein spikes are multiple myeloma. So how can we tell multiple myeloma from Waldenstrom's? And what you have to do then, you have to do a test called immunofixation. That's the M spike result in this patient. An M spike should be 0, it's 1.9 in the lower right there. But you do a test called immunofixation, and that will tell you if you have this big protein that Peter talked about called IgM, causing the monoclonal protein spike, and that's when you say, aha, this probably isn't myeloma. This is an IgM protein causing the monoclonal spike. Do you have that thing called Waldenstrom's? And so they start to wonder about that. And sure, you measure the IgM here, and it's elevated at 1900. So that's a very common way for people to get into the WM club. It's through an elevated total protein, electrophoresis, find the IgM in the blood, measure the IgM. So I'm going to pivot now and talk a little bit about unusual Waldenstrom's complications. So the most common, reasons that people are symptomatic from the WM by far and away, it's anemia, it's fatigue, and I would say the great majority of patients that I have seen over the years with WM who have been symptomatic have been so because of fatigue with or without anemia. But sometimes the WMers throw a little change at you here, and we're going to talk about some of those. Now, there's a group of patients to which Peter referred who have very unusual complications, but they actually technically don't meet the diagnosis of WM. And so to have WM, when you do that bone marrow test, you need to find 10% or more of those LPL lymphoma cells in the bone marrow along with the IgM. But some of you here and some patients that we see who are having medical problems and symptoms, they have it with a very low IgM amount in their blood. And sometimes there's not even that MYD88 that Peter talked about. And so you can have IgM-related disorders causing problems, and WM doctors see those patients as well. The other thing to keep in mind is that just because you had a certain presentation when you were diagnosed with WM doesn't mean that you could not develop a new problem related to WM over time, because the hope with WM is that you're going to live decades, And so we have to watch very carefully to see if you're developing any of these complications that can occur after you've been diagnosed. And they include this thing called amyloidosis, peripheral neuropathy, Bing-Neal syndrome, which I'm not going to talk a lot about, but Bing-Neal syndrome is when the WM actually infiltrates your central nervous system with a lining of the spinal cord or around the brain and causes problems, or something called transformation. And transformation is when the WM goes from an indolent, well-behaved lymphoma and says, I'm going to morph myself and turn into an aggressive type of lymphoma. And we're going to talk about what we have to do with that. So WM doctors, whenever we see patients in the clinic, we're always going through our head and saying, make sure this patient doesn't have symptoms of amyloid or neuropathy or Bing-Neal or transformation. Are they throwing me a curveball or not? So one of those curveballs is cold agglutinin disease, which isn't really WM. Cold agglutinin disease is one of those IgM-related disorders where patients have low amounts of IgM in their blood, but they have these weird symptoms, and they can be tricky. And we're actually a little more fortunate to be able to diagnose this in Colorado due to the fact that, except for this year, we often get very cold winters. So this is a case, one of our patients. So a 71-year-old woman was told years ago that her blood hemolyzed. Now, what's hemolyzed mean? Hemolyzed means when you drew the blood out of the patient's arm and put it in the tube, that the red cells broke down. They were broken down. And it has a very funny color to it when that happens. And so then she got checked out a little bit later for this, and she had a very small M spike. That's that IgM spike to which we referred. Only 5 to 10% lymphoma cells in the marrow, nothing on the CAT scan. And then the doctor checked her bone marrow for that MYD88 mutation, which Dr. Forsberg told us is present in 95% of the WM patients, and she didn't have that. So low LPL in the marrow, no MYD88, lowish IgM, but she's hemolyzing your blood. And when skiing in Colorado, the tip of her nose and ears would turn purplish in very cold weather. It turned purple. And so she had we did a test, and she had a lot of these things in her blood called cold agglutinins, meaning that when things get cold, the proteins begin to coagulate or coalesce. And remember, this is a big protein, right? And then when that happens, things can get kind of sluggish. But her anemia worsened, and you can see there on the left there, on the right rather, you can see a typical patient's on the left of that picture there. And so what happens when you draw blood and you spin it in a centrifuge, the red cells go to the bottom. That's the dark purple stuff you see in the picture there. And the plasma is on top. And if you're not hemolyzing, breaking down red cells, the plasma should have that yellowish appearance. But when you look on the sample there on the right, you can see on the left side there, that's somebody who's hemolyzing. There's a lot of that pink stuff. That's hemoglobin, a breakdown product of the red cells that's there. So we gave her 4 cycles of bendamustine rituximab, and she's better. So what is cold agglutinin disease? Again, that's a rare disease where the red cells get tagged by this IgM antibody. And then what happens when you have an IgM antibody on the surface of the red cells, your immune system looks at it and says, that's not supposed to happen. You've been tagged. You're getting removed. You're it. And we call it cold because this occurs typically in colder temperatures. So the analogy I use with patients is the following here, which is Pac-Man. And so Pac-Man is the immune system, and right there. And then the red cell is that guy right there. And so what happens is you get that red cell tagged with IgM, the temperature drops. Next thing you know, Pac-Man is Pac-Manning the red guy there. Okay, what about bleeding problems related to Waldenstrom's? So some of you present with bruising, and this can happen. Again, not common, but common enough where we have to be on the lookout for it. So one of the things that can cause this is called acquired von Willebrand's disease. We'll spend a minute on that. Low platelets, the medical term for that is thrombocytopenia. Platelets are thrombocytes. And if it gets really low, then we call it ITP, which stands for, you guys will like this, immune thrombocytopenic purpura. You can bleed from amyloidosis. And also, sometimes our treatments cause bleeding. And a very common treatment that causes bleeding or bruising are the BTK inhibitors. That's the ibrutinibs, the zanubrutinibs, the acalabrutinibs. Those IBs have an antiplatelet effect. And so it's very common for our patients who take these things. They come in your office and they say, what's going on here? And they show you bruises on their forearms from working in the yard. Let's talk about acquired von Willebrand's disease. So I'm always on the lookout for this, especially with the third bullet there, when patients have very high IgMs, often with a CXCR4 mutation. These are patients where I always go, could they have acquired von Willebrand's? And von Willebrand's is a little bit like hemophilia. And it can be mild or it can be severe. And so it can be picked up. So I always look in patients who have high IgMs. I always look for this disorder, and if they have a CXCR4 in particular. There's a screening test which is called a PT or PTT that if it's normal, the patient almost certainly does not have the acquired von Willebrand's, but if it's abnormal, they could. And then if you think they could, then you have to do additional tests that are specific von Willebrand's disease tests. And you can check all that stuff. Now, the good news about von Willebrand's is that it gets better when you treat the von Willebrand's. And so if you have these patients with a high IgM and they're bruising, they're bleeding, and they have the acquired von Willebrand's, and they're acting like a hemophilia patient, and you treat their WM, the IgM comes down, and their bleeding problem gets better. So this is ITP. So this is a similar mechanism as with hemolytic anemia. Remember we talked about Pac-Manning the red blood cells? The same thing can happen when the immune system Pac-Mans platelets. And what happens is the WM cells get a little screwed up and you have what I call friendly fire. And so you have the WM cells attacking their own platelets in their own body, making the platelets go low. And I have had patients with WM who are just minding their own business, doing fine. Their WM's behaving. They're not having symptoms. Nothing's going on. And next thing you know, you get a call from the primary care doc or from the dermatologist saying this patient has a rash over their shin bones. And you look at the rash and you go, this is petechiae. And petechiae is the medical term there you see on the right there. For small little bleeding in the small blood vessels from a low platelet count. So one of my patients was a 59-year-old, very healthy, who developed nosebleeds, gum bleeds, big hematomas, and petechiae, and his platelet count was 1,000, okay? 1,000. Normal's between 150,000 and 400,000. We did a bone marrow biopsy, had 30% LPL. The IgM was 2,900, meeting the criteria for being diagnosed with Waldenstrom's, had no other symptoms, but with the ITP there, then you got to go fixing it. And I don't know if I have this slide in here or not, I don't. But if you go to fix ITP, we have a couple different choices. If the patient's symptomatic from the Waldenstrom's and has ITP, just treat the Waldenstrom's like you normally would. But if they have ITP, but they're not otherwise symptomatic, sometimes you can get away with less treatment. A little bit of steroid medicine, a little bit of rituximab, a little bit of gamma globulin. There are different tricks that we have to treat ITP that often work. So if we have a patient who has WM and ITP, we still have to say symptomatic or not. Do I need to go full court press in this patient and treat the WM, or can I just do lighter treatment and fix the ITP? I doubt there's anyone in the room here who's had ITP from Waldenstrom's. It's not very common. It's about 4%. Any ITP patients in here? Yeah. And so anyway, amyloid is something where I always put the fear of God in myself looking for amyloid and educate my patients about this as well. And the reason is that amyloidosis is really, really tricky. It's tricky to diagnose. It's tricky to recognize. It can be challenging to treat sometimes. And thank goodness it's not very common. So what is amyloid? This takes a lot of explaining to patients. Remember Dr. Forsberg showed you this protein in the upper right here. That's IgM. Remember with the 5 parts to it? And then you have the big part of the protein, but you also have these things called light chains that I very poorly circled here before my animation skills were better in PowerPoint. But anyway, those are the light chains. And what happens in amyloid is that these light chains that normally are just hanging out as part of the IgM protein, sometimes these are mutated, screwed up light chains. And light chains, if you look in the lower right there, they're supposed to just get recycled through our body's garbage disposal. But sometimes they don't recycle very well, and they turn into a toxic protein called amyloid. And then the thing about the amyloid is the amyloid can then go and it infiltrates different organs in the body, or it can infiltrate different organs in the body. And those are shown on the lower left there. So if you have amyloid, it's most likely going to affect the kidney, but it can also affect the heart, peripheral nerves, the autonomic nervous system, which is our involuntary nervous system that regulates, for example, blood pressure or how our intestines work. It can do other things as well. So when do we think about amyloid? So the answer is, I always think about it. I always think about it. And so because roughly 6% of our WM patients over their lifetime can actually develop AL amyloidosis. And so, again, this is one of those things where I have had patients of mine with myeloma or with Waldenstrom's where the amyloid snuck up on me. And so that's why I really try to just in my head always go, make sure, Jeff, you're not missing amyloid here. And so there's not, to do that, most of it is based on just asking your patient how you're doing, just talking to your patient. You know, how are any problems that look like they could be amyloid. But there's a few things I do, you know, that I consider a lot. And one is there's a blood test that we can do that screens pretty well for cardiac amyloid, and I'm overly compulsive for this, and I check this frequently, you know, at least annually in my patients. And then I always make sure that they're not leaking protein in their urine. That can be another sign of amyloid sometimes. But mostly it's clinical suspicion. And if we suspect that a patient may have amyloid, then we have to go into full investigation mode. And we usually end up doing a biopsy of some kind to try and diagnose it. And I'm just going back here. I would recommend everyone here, there are a couple great Torch articles that have been done over the years on amyloidosis, written by world experts in this disease that are really, really, really good, and they're smarter than I am about amyloid. So if you have any questions, you go home and say, okay, Jeff really scared me about amyloid, just go to the Torch and read Dr. Merlini, and I think Dr. Strosek also has, and Dr. Gertz. There might be actually 3 AL amyloid torches over the years. Amyloid, WM can affect the kidney. And this is a patient of mine who in 2001 was diagnosed with smoldering WM. We observed him until 2005. And then back then, rituximab was very commonly given. He got some of that. But every time this guy got sick, his creatinine, remember that kidney test I showed on the chemistry, shot up. So finally I said, okay, we gotta figure this out. So we did a kidney biopsy. And he had a bunch in his kidney. He had a bunch of IgM in there. No amyloid was in there. And there was also infiltration of the lymphoma through the kidney as well. So we had direct infiltration of the kidney from his lymphoma, which again is not common, but can be seen. So we had to fix that. So transformation, I think I'd put transformation and Bing-Neal syndrome as maybe some of the scariest things, Lisa, you think so, for WM patients. And what transformation is any slow-growing B-cell cancer can morph or change into an aggressive B-cell cancer. And that's called transformation. This can happen to CLL patients or marginal zone lymphoma patients, and it can happen in WM. And usually if it morphs into something called large B-cell lymphoma. And when this happens, patients, it's usually not subtle. Patients don't come in for a routine visit and say, hey, am I transforming, doc? No, it's they come in and say, hey, doc, something's wrong. I have this lymph node that's growing very quickly. I have fevers. I'm having these drenching sweats at nighttime. I've lost weight unintentionally. I just don't feel good. My LDH in the blood is high. And then we do a PET scan. And usually the PET scans in WM are pretty boring. They don't show usually terribly much. But when you have transformation, they light up like nobody's business. And so if we suspect transformation, we have to do a biopsy and demonstrate that this is not LPL, but it's an aggressive large B-cell transformed lymphoma. Luckily, this is not very common. But we used to use a treatment back in the day in early 2000s called fludarabine. Commonly, we used that to treat WM, and we know that patients who had fludarabine had higher chance of transformation. So the scary thing about transformation is that it can occur at any time during the disease. And so on the top line there, you have someone who got diagnosed, they were watched for 4 years, they went through transformation. And on the bottom there is someone who went through and had transformation with an MYD88 mutation, and they tend to be a little, sometimes a little less aggressive than someone who doesn't have the MYD88 mutation, because the ones who don't have MYD88 actually have higher rates of transformation. And then the bottom, you have someone there who's got MYD88 wild type, and they can get to transformation sooner, like I just said. So the thing is, you can see transformation right after a diagnosis or years after a diagnosis sometimes, and it's a random event. That is, it's not like the longer I go, am I more likely to have transformation? No. If I got treated with X, Y, or Z, am I more likely to transform? No. It can just happen at any time. And if it happens, what we have to do is we have to treat the aggressive lymphoma. So we're not talking about bendamustine rituximab, we're not talking about the BTK inhibitors, we're talking about aggressive multi-agent chemotherapy. And more often these days, it was in 2024, I think we had to give 3 people CAR T-cell therapy for transformation at our center. And so it was a banner year for that. Coming up near the end of my slides here, because I've been fooled on this one before, rarely WM can have painful bone lesions. And later on in this educational forum, Dr. Shirley Desai, and patients always say, how does she spell her name? But it's D'(S)A. She's going to talk about neurologic complications of WM in more detail. But I have a few patients that have had painful bone lesions from their WM. Okay, let's pivot to communication for a few minutes. So be organized, keep good records, set the tone with your doctor, be assertive, be understanding, come prepared, and never rely on your memory. Write things down when you're with the doctor. So good organization. So plan for when you see in the doctor, the doctors are busy. And we have long appointment times, which is good, but a lot of doctors don't have long appointment times. So be prepared. Have your questions prepared in advance. One of my patients is here and was like the king of, I'm looking at you, of well thought out, multiple questions, referenced often, do your research. And make sure when you're with the doctor, your doctor knows what your priorities are for the visit. Sometimes the doctors get on they get on their thing that this is what's important to me, but you have to make sure your doctor knows what's important to you for that visit. Visits can be stressful, so if it's a big appointment, bring extra ears. And what are some good communication tips? So doctors, I'm not terribly good. I think Peter's better at reading minds than I am. So make sure that you tell us what's important. And it's very critical early in the appointment to say what's important to you. For example, the example I use is doctor says, I'm so pleased your M spike is down. Did you get your medication refilled? Basic stuff. And the doctor said, and the patient says, I'm good there. I'm glad my M spike's down, but I feel worse. I'm having lots of joint pains, aches, fatigue, and bruising. It's important that we discuss that today. So that's a good tip for when you're seeing the doctor. Be understanding. The doctors don't need to handle every question. How come my zanubrutinib prescription is late at the specialty pharmacy? That can go to somebody else. And so, and then also, I think if it's a big appointment or any appointment, ask the doctor if he or she is comfortable having it recorded, especially for big visits. And then whenever I give information to patients, I write it down for them. Because I know that if I'm just sitting there saying, okay, I think your disease is getting worse, we have to pounce on this. I have a clinical trial with a BTK degrader, but I could also use a BCL2 inhibitor. And then we have this bispecific coming that's really exciting. If I tell that to my patient and they walk out of the room, I bet the chance of them retaining any of that's about 1 at the highest. And so I write things down for patients, and you can ask your doctor to write things down as well, or just record it. So navigating treatment decisions, these are big appointments. I call these treatment crossroads. This is when treatment has to be initiated, altered, or resumed. And this is a meeting when you know this is coming, bring extra ears, record things. Sometimes you need a longer appointment when this happens. And there are key questions to ask, like, what are my options? What are the pros and cons of each of my options? Should I get another opinion? are there any clinical trials available to me or anywhere else? And there are places you can go to look for clinical trials that I've referenced here. And then I need to know what the costs and side effects are, just not how well they work. And in WM, it's really important to know that if you're not meeting the criteria that Dr. Forsberg referred to earlier, is it reasonable to defer treatment? So this is less and less common these days, but for a long time, by far and away, the most common second opinion that I saw for WM is somebody who was smoldering, who didn't have a reason to start treatment, and their doctor freaked out because the IgM was high and wanted to start treatment. The patient went to IWMF and said, I'm going to go get a second opinion. Fortunately, we don't see that consult or second opinion nearly as much as we used to. Get informed. Ask about side effects. It's really important to ask about side effects. And so this guy in the right here, Herman's great. No side effects from that medicine. And also make sure you know how to take the medicine. And so take one of these with water a half hour before you wake up every morning. I've probably told patients that. And then the bottom right there just looks at medication errors, whether or not, based on whether or not things were explained to the patient. So just explain to the patient how to take medicines. It's a big, big deal. And make sure you know how to take them. I think pharmacists are very helpful in this regard too when you get your medicines filled. Medical jargon. I've shown this slide before here, but I love this when doctors start talking medical jargon to patients. And then, and you can see, this is a Far Side comic on the left there, and you can see what the guy's saying to the dog and what the dog hears. That happens a lot to doctors as well. So I want to spend just 2 slides, and then I think I'm going to wrap up here, showing a graph that I don't know what Dr. Kapoor is going to show or the other doctors presenting at the Ed Forum are going to show when it comes to treatment and how well treatments work, but doctors love showing these. They love showing these graphs. And these are called Kaplan-Meier curves. And this is an example of one from the Aspen trial, which compared ibrutinib to zanubrutinib. And it talks about PFS and OS in the ITT population. Now, most of you know what that means, right? So PFS is progression-free survival, which means if you didn't die or relapse. And overall survival means exactly what it says. Are you dead or alive? And in ITT means the intent to treat population. So they show these slides all the time, and you look at them, and you look in the left there, and you go, okay, if you're on zanubrutinib at 3.5 years, your chance of being alive in remission is 78%. Your chance of being alive is about 88%. But remember, these are curves that apply to populations of people, and they're estimates. They don't apply to individuals. So when patients ask me, what's my chance of being in remission or being alive? And I tell them it's 0 or 100, pick one, you know? And so that's what these curves show. And these are Kaplan-Meier curves, and doctors show them all the time. And they're estimates of survival or remission duration or that kind of thing. Remember, they're probabilities. They refer to populations. They don't refer to individual patients. And I'm going to stop right there. And pretty much everything I said today, and Peter said, is found at IWMF.com. Everything is there. So, thank you.
I think we have a, yeah. See if there's any questions.
That was fabulous. Both Dr. Forsberg and Dr. Matous just was clear, and it was wonderful. But are there questions that we would like to? I'm sure there are. I know, and we're all shy, and we're sort of. Where are you going?
I'm going to run out.
We're handling the mics.
I'm going to get the mic.
We're going to ask.
We
There's
can't
2 of
afford
us.
to have
There's 2
you
of us.
guys
I got
give
it.
out mics. Holy smoke! Okay, go ahead.
Yeah, no, we'll answer questions on the fly here.
Yeah, but we've got it. We've all got to hear the questions, so this is great.
I ended up with a severe rash that involved a lot of itching. Is there any relationship between the ITP when you have, and my dermatologist had never seen this before, between the ITP and also having an irritating itch?
I think
We have a rash expert in the back of the room here, It's our nurse practitioner, Kate, who's going to talk about dermatologic complications of WM. Is this a Schnitzler's, I wonder, Peter?
Yeah, and there are, so like Jeff said, tomorrow you guys are going to get like a full hour on dermatologic complications. So it'll be like a perfect place because the answer is it's kind of complicated. Is that there's different things. I know, yeah. So there is that, there's different ways that WM can cause, skin changes and meds can cause skin changes. So to pull it apart, there are some different layers to it, but it's a great session tomorrow to dedicate a bunch of time to it.
Just before we keep going, it's not fair to ask for direct medical advice. It's just simply not fair because they've given their time. You can ask a question about anything. You can say there's an itch. Does that ever have? But we can't ask about ourselves because that is just totally. Anyway, that makes sense if you think about it for a minute. So, Jeff, there's a microphone at the back there. Okay, who's next?
Okay, this is not about me. It's about anyone. So it's a generalized question. So you guys talked about organomegaly and when to treat. And I've found that there's very little information about what to do if your only symptom is organomegaly and everything else looks hunky-dory. So do you have any advice for just the general patients, not particularly me, but what to do in that case?
I think that's perfect because you're right. It's nuanced, I think, and that's true for a lot of things. When is a spleen symptom enough to trigger treatment? When is lymph node enlargement enough? It's an area where we don't set super rigid, cut and dried thresholds. There may be areas where we sort of say, bulky of 5 centimeters in diameter for a lymph node's enough. But where I usually think about it is if it starts to impact daily life. So basically, if your spleen gets big enough that all of a sudden your appetite is changing or you're losing weight, those are discrete indicators of symptomatic enlargement of the organ. Liver, with the liver, it may be that it's starting to fill the abdomen, or it may be that it's starting to impact liver function tests, and that would be a clear trigger. Lymph nodes, if you're that can be a little bit patient specific. So if you sort of say, this is getting uncomfortable, or, I don't like the way that I look all the time, I'd really like to get this treated. Those are totally appropriate indicators for when we would move for treatment. Our treatments have gotten better and better too. So while we do have these thresholds, we know that we're moving into things that work quite well, that preserve quality of life. So it doesn't have to get to an extreme place. I often am trying to in patients where we've been watching and waiting for a long time to say, getting over that threshold is not something we have to worry about too much. We're going to do great from there. So we want to make sure we're sort of, moving in that direction if things are turning towards that, affecting day-to-day life, especially.
Katie, could you come and take Dr. Forsberg's mic? Yes.
Hi. You had mentioned that neuropathy is considered a complication of WM. My wife, that was one of her first symptoms years ago, and doctors couldn't get to the bottom of it until we found out about WM. But she not only has it in her peripheral limbs, but like she has it all over, and it comes and goes. Where do you go from there? If it's considered a complication, where do you go from there?
So again, the world's expert is speaking at this conference, Dr. Desai, on IgM neuropathy. When there's neuropathy might be the most challenging symptom next to fatigue that we can hear from a patient, because the potential different causes, the list is huge. So it takes a lot of work to try to get to the bottom of it. It's very challenging to treat. There's no consensus on what the best treatment is. And it's just a very, very difficult clinical situation in general. Yeah. Dr. Desai is your person.
I would say, if you look at our spreadsheet, when we try to simplify it, it's like the most insane charts imaginable with things pointing to another. I would say it's an area where multidisciplinary care is really important. Finding both a good hematologist and a good neurologist who can hopefully communicate with each other is probably the best thing you can do if you have neurologic symptoms that are complicated and hard to get to.
Michael?
First, thanks to both of you for the excellent presentation. I've been reading recently that some WM patients are presenting with more plasma cells than B cells. And so my question is, how do you then differentiate that from multiple myeloma? It might be that you look at the M spike and it's IgM. Well, like, what if the M spike is IgA, which could be lymphoplasmacytic or it could be multiple myeloma?
And this can be complex. I mean, this is certainly an area where some of us who are more, in the clinic treating patients have to rely on some of the guidance from our pathologists who are the experts in the lab. So having, a second pathologic opinion, if your biopsy was done in a community center, making sure that's sent out for a second, bone marrow opinion can be helpful. The presence of MYD88 goes a long way. The fact that in WM, 95% of patients have an MYD88 mutation, if you have that present, but there's a dominant plasma cell population, you probably still have WM with a plasmacytic profile, versus if you don't have MYD88, and then there's some molecular characteristics that are more classical for myeloma if you have an 11-14 translocation. So there are some things at the molecular level that can help us beyond just what the cells look like under a microscope.
Thank you.
When talking about the ITP, Dr. Matous, you mentioned one of the possible treatments was a little Rituxan. Could you define what a little Rituxan is?
Yeah, very often a weekly treatment for 4 weeks will put it to sleep, and then often that's all it takes. Sometimes you need to weed and feed a little bit after that, but usually that's all it takes.
You mentioned the Waldenstroms can sometimes be associated with von Willebrands. Now, can you explain how they might be connected? Because I think you can have either one stand alone, but when they come together, are they both caused by the same problem?
And so what happens is the IgM attacks something called factor VIII and von Willebrand's factor that carries it. And so it's an IgM problem. It's a problem caused by the IgM interfering with the normal coagulation in the body. And that's why when you treat the WM, the von Willebrand's gets better.
Are there any other questions? I think oops, one more. Sorry. I'm sorry, this is it. They've cut me off, okay.
I was just curious, doctor. So if you said with ITP and that rash, the Petittia, that you have this treatment with prednisone and Rituxan. Is there a way to test, though, if that's what it is? Or do you just try that therapy, and if it works, it works?
Yeah, so there's no test we can do to say ITP is it's basically a clinical diagnosis, so we always suspect it when the platelets are really, really low. So if you have a platelet count that's single digits or less than 20, that's more likely to be driven by this immune-based destruction of the platelets, whereas if the thrombocytopenia, the low platelets, is driven more by bone marrow involvement from the WM, often that's when the platelets are 50, 60, 70. So probably the severity of the ITPs, or the low platelets, is the biggest differentiator clinically, but there's no test, unfortunately, we can send out, which is different than the other IgM interacting with red cells. That we do have tests for cold agglutination and for cryoglobulinemia, but ITP specifically, we don't have a direct lab test for.